Hello. In the next 15 minutes, we will have a short talk on the acute hepatitis C epidemic in MSM and what we have actually learned so far up until 2020. Upfront, my conflict of interests. Now, as some of you might be aware, the epidemic of acute hepatitis C, particularly in HIV-positive MSM, started in Europe with first cases being reported from London and then other capitals followed. And to date, we have some sort of global epidemic that is still going on, and most of the countries have reported at least some cases, if not really high case note numbers throughout the globe in HIV-positive MSM. And indeed, if you compare the risk groups for hepatitis C infection with the HIV-negative population, the ones being in prison and the MSM population are at highest risk of acquiring an hepatitis C infection, and even more so than the general HIV-positive population or sex workers or people who inject drugs. And that's very meaningful for clinical life and screening purposes. If you look at the HCV transmission risk groups based on the European CDC data, you can clearly see up on the top that the MSM population is most likely to be diagnosed during the acute phase of the infection, whereas intravenous drug users are more likely to be tested positive at some point during their lifelong, potentially chronic hepatitis C infection. So the acute hepatitis C infection really is something that we predominantly see in men who have sex with men. Now, what puzzle pieces have we collected so far to sort of give us a clearer and more profound picture of the epidemic amongst HIV-positive MSM? Most cases often have concomitant STDs such as syphilis. The patients with acute hep C more often practice high-risk sexual behavior going along with the traumatic sex practices that might lead to mucosal damage and then increase the risk for bleeding, which will then be an entry port for the HC virus. Chemsex on top enhances the risk for blood-blood transmission if you use unsterile needles. We also know that hepatitis C is shed into the rectum of a co-infected man, which also might increase the risk of transmission while having unprotected sex. The mucosal dendritic cells and Langerhans cells are able to capture hepatitis C and then are very efficient to sort of transport the virus into other cells of the body. And we also know that once the virus has access to a certain community, in this case it's the MSM community, it spreads via sexual networks. And in addition, over the last years, we have also collected some more puzzle pieces. This is data from Germany showing that actually the highest risk of reinfection, so getting a new hepatitis C infection after the first one or the second one or the third one, actually is being part of the MSM community, and the risk is much higher even when you compare to intravenous drug users. So the population that should regularly be screened for hepatitis C reinfection once there has been an infection that spontaneously cleared or was treated successfully should really be the MSM population. As a rule of thumb, you can say that within the first 2 years, a quarter of all patients that you see with an acute hep C have a risk of acquiring a second or a new hepatitis C infection. This is further supported by recent data from CROI this year, which was taking place virtually, as does this conference as well, due to the COVID-19 pandemic. Again, showing that the risk for hepatitis C reinfection in HIV-positive MSM, in this case, this is data from a cohort from New York City, really was when semen and rectum, so unprotected receptive anal intercourse was reported. With that, the risk was much higher of reacquiring an acute hepatitis C infection. What we also saw, and this is data from the European acute hepatitis C cohort called PROBE-C, that the chances of spontaneously clearing the acute hepatitis C infection is very low. In this cohort, the rate was around 11.9%. So close to only 1 out of 10 patients will actually be able to spontaneously clear the acute hepatitis C infection, and all others, close to 90%, will end up having a chronic hepatitis C infection. Now, this is clinically very meaningful because on the other hand, we saw declining treatment rates. So on the one hand, we have an infection that very rarely spontaneously clears and goes away, but requires treatment. And on the other hand, we see increasing data that the treatment rates, particularly with the new DAAs that are given interferon-free and ribavirin-free, very short course with minimal side effects, particularly compared to ribavirin and interferon, that those treatment rates are really going down, and that's further fueling the epidemic. So we have more and more patients with the chronic hepatitis C who receive less and less treatment. But luckily, we have enough data to support the use of DAA in the setting of acute hepatitis C infections. So over the last years, several cohorts and randomized trials have reported promising data, and the most recent one has been presented at CROI this year from the REACT study initiated by our colleagues from Australia. And they compared the combination pill of sofosbuvir velpatasvir 6 versus 12 weeks in participants with an acute hepatitis C infection. And to cut the story short, the 2 bars here to the right show you the response rates, so the cure rates as we are 12, 3 months after end of treatment. And you can clearly see that the short treatment arm of 6 weeks didn't do that well. The cure rates were much higher among the patients that were treated longer with the 2 1-pill DAA strategy. And that's mainly due to patients relapsing. That's shown here in the table on the last line. So in arm A, which was the short treatment arm, 9 patients relapsed compared to only 2 in arm B. And when you look at the viral loads at baseline shown here in column 3 for both treatment arms, so the 11 patients that relapsed in total, you can clearly see that they all had very high hepatitis C viral load at baseline. And that means that 6 weeks of treatment is just not enough for the highly viremic patients with an acute hepatitis C infection. And that signal has also been picked up in other trials that were published previously. So a shortening of treatment below 8 weeks, which is currently the minimum when you treat hepatitis C at the chronic stage, is not recommended based on these data to treat acute hepatitis C. So what to do if a lot of physicians hesitate to use the DAAs in the acute setting, although there's substantial data to support their use? There was a second gathering of the European AIDS Treatment Network, and there's an acute hepatitis C infection consensus panel that gathered in summer last year to sort of speed up DAA usage in the treatment of acute hepatitis C in MSM, so with or without HIV infection. And they clearly, very boldly made the new statement of redefining acute hepatitis C to sort of find a way around the product informations that only allow DAAs to be used at the chronic stage. And the NEAT ID consensus panel suggested to remove the term acute hepatitis C and only talk about recently acquired hepatitis C infection or recently acquired hepatitis C reinfection and early chronic hepatitis C infection. And by this sort of bypassing the wording acute hepatitis C and the potential conflicts that you might run into with the health insurances when it comes to reimbursement of treatment costs. And in addition, the European AIDS Clinical Society picked up these recommendations as well and amended their algorithm for management of recently acquired hepatitis C infections. So you can already see that they also removed the wording acute hep C. And they clearly recommend to do a second HCV RNA measurement once the diagnosis has been established 4 weeks after diagnosis. And if you don't see a 2-log drop, and that's data that comes from the probe C cohort as well, if you don't see a 2-log drop in hepatitis C viral load after 4 weeks, then it's extremely likely that you're looking at an early chronic hepatitis C infection, and then treatment should be discussed and initiated, and the episode should be treated as a naive, non-cirrhotic hepatitis C infection. So really very bravely, very early on, after 4 weeks, you can already start discussing and should actually start a DAA treatment in acute hep C. And if you do that, just to sort of encourage you to not think about it, but also to do it in daily life, if you do that, you can really see a decrease in newly diagnosed hepatitis C infections. This is data from the Switzerland, which was shown last year at CROI and has in the meantime been published. And they screened all their patients in their Swiss HIV cohort for hepatitis C infection and offered treatment to the ones that were tested positive, and then sort of had a rescreening interval and could really see a significant decrease, around 49% in the second, in the rescreening phase. So a substantial reduction in new cases of hepatitis C just by increasing treatment for everyone that has been diagnosed with an acute or with a hepatitis C infection in general. And similar dates have been shown at CROI last year as well, coming from London, where they had a different DAA policy. And since 2015, via the NHS or clinical studies, prescribers were allowed to give their patients access to DAAs in the acute hep C setting. And they could see a substantial decline in new infections since 2015, with the curves of first infections going down, and unfortunately, reinfection curve going up. The colleagues from Amsterdam picked up very early on a new signal, as we are living in the era of PrEP, pre-exposure prophylaxis against or for HIV. And they were able to show also acute hepatitis C cases in MSM taking PrEP. So the phenomenon of acute hep C is not only restricted to HIV positive MSM, but to the MSM population in general. And the risk factors were younger age, more sex partners, potentially injecting drugs or chemsex, and receptive anal intercourse. And since then, several reports have reported similar signals from various countries around the globe, and this is just some snapshots of the publications. But it has to be said that DAA treatment, although it's highly recommended to really get the curve of new infections down, also the ones for reinfections, DAA treatment alone will not be enough. This is modeling data from Natasha Martin with various treatment intervention strategies. And if you focus on the purple curve, you can see that only if we treat all newly diagnosed rather early on within the first month, and also the ones that are already known to be infected for quite some time, and if we add some sort of behavior reduction counseling to that, only then will we be able to really bring down significantly the curve of hepatitis C new or reinfections in HIV positive MSM. The next sort of problem that was highlighted at this year's CROI was the shifting in virus strains. So far, there were always clusters reported, and now over the last years, starting in 2014 or 15 in this analysis, the hepatitis C genotype 1a strains were sort of clustering less, and communities were affected by increasingly more by viral strains that were so far not reported within this community, and that's just reflecting that with online tools and pre-corona, a lot of travel opportunities, of course, people meet throughout the globe and then can get infected with viral strains that are not the most prominent ones in their country or hometown. And I think this then should lead to a very important role of the community in terms of counseling and chemsex groups, and really support and help MSM, be it with or without infection, be it on PrEP or not, to counsel them for acute hepatitis C risk and needle sharing, use of sterile sex tools, etc., to bring down the curve of acute hepatitis C infection in this high-risk population, as we've just seen with the modeling data by Natasha Martin. And overall, I would like to say in conclusion that all of us have to understand that the chronic infection is established very early on. After 4 weeks, you can already decide that this is an early chronic infection, and then treatment should be initiated. The increased treatment rates then will hopefully impact the number of new hepatitis C infections. We have to be aware that there might be a spread among HIV-negative MSM who are on PrEP, and that sort of might counteract the trends if we don't initiate treatment in these patients early on as well. So we really should screen PrEP users as well as HIV-positive MSM regularly for first or re-episodes of acute hepatitis C done with detection of HCV RNA. We clearly need behavioral interventions, but at least in my country, we really lack trained experts in the field of chemsex, and I'm very sure that without a vaccine, we will probably not be able to eradicate hepatitis C off the globe. Thank you for your attention.